I had to present something similar a few weeks ago, but was in the radiation oncology meeting, so I'm believing that my heart rate now is in a different range. This is my disclosures. Few of them are relevant. So probably we all agree that the train of focal therapy already left the station and it's going pretty fast. And if you are not on board of the train, you have to jump on it. And the main reason is the change in the philosophy. We should all agree that now we have we can change for the control of cancer or delay progression or delay whole gland treatment and more focus in what our patients are telling us is to keep the quality of life. For many years, and probably many of you start doing this few years back, the main barrier was the lack of level 1 evidence. But we have good evidence, probably not coming from the randomized control trials, but we have longitudinal data that support that what we are doing is the right way. One of the examples is the excellent talk of Dr. Lepore. I don't want to repeat the concept that was already delivered, but with this, I just want to highlight that we need registry to do this. And it's obvious to find a better way to select patients, but also as a training purpose. Probably we all record our robotic surgery, and when we review the video 1 month after, we realize something that we can do better. When we go back with the registry, we can see where we are failing. We all know that it's a lot of interest now in the US with a lot of academic centers doing focalized treatment, and we don't have to start from the square one. This course is a good example. AUA has 2 courses, and now Cleveland Clinic have 1 yearly course also about focal treatment. So the time is right because the goals are aligned. Which goals? From urology standpoint, urology, it's very technological focused. We embrace and we adopt early new technology. And the goal from our patient, that our patient knows better that probably they are not going to die from that prostate cancer. And as Dr. Gill mentioned, we have to stop doing more and more radical prostatectomy for intermediate prostate cancer, and we have to offer new alternatives. So the invitation is to think in prostate cancer as a continuous. We need to offer some cut, especially when we want to cut the transition between active surveillance to radical treatment. And the patient will die from high-risk prostate cancer. So as we saw yesterday, that is one of the areas to increase survival. So focal treatment will not replace active surveillance. We enable that. If we treat the area of cancer that will progress, the index lesion, we can keep the patient on AS for a longer period of time. But what is the problem? Is that we all know that prostate cancer is multifocal, but now with more evidence with MRI, given that focalized treatment is an image-based treatment, we can understand where the bad guys are. But we all know the downside of the MRI, and it's not perfect. So now we know how to do better biopsy, and as the previous speakers told us, instead of just going to screening to detect the cancer, use as a mapping to deliver a better treatment. About the energy, Dr. Abreu did a wonderful review. I just want to point out that, of course, we have to master the energy. But the concept that I want to share with you, that is a good alternative to have more energy available. Of course, to increase the performance, right? But also because you need volume of patient. If you are having just one energy and you do that procedure, every 2 months, probably you and your team is not going to get the proficiency good enough to show your outcomes. And of course, we cannot forget that we are talking about prostate cancer. As an uro-oncologist, we have to understand biology and not talk just about the technique. We all know that focal treatment is a balance. We have to ablate, destroy the area with cancer, but we know that if we ablate more, the PSA will drop significantly, so the patient, the family, and even yourself, it's going to be more happy because the PSA will go down. Also, if you ablate more, the risk of recurrence of the cancer is going to be even lower. What is the downside? That is, we are doing this to keep the functional activity of the patient. That's why the balance comes from. How we do that? This is a busy schedule, but I did that in purpose to tell you that many people that is here today did a wonderful job trying to do consensus to tell us this: what are the good candidates for focalized treatment? Or we know where the failure came from. One of the first things that you have to start if you're starting building your focal therapy program is not to fail with your first patient. So we know where we have to focus our attention to try to reduce the risk of that failure. We all know that based in the location and the volume of the cancer, we can tailor the treatment based in the energy. And we know that every energy has different capabilities. Some of them are easy to shape. So if I want to go more precise, or the location is next to the external sphincter or the neurovascular bundle, it's going to be my first choice. And other one, I can do wider ablation. As Dr. Lepore mentioned, I mean, when you do a radical prostatectomy, in 20% of PT2, you're going to have positive margins. And that positive margin does not mean always that the patient is going to have, bad outcomes. I'm bringing this up because we know the numbers, oncological numbers after focalized treatment, but in-field or outfield recurrence doesn't mean all the time that we are going to have to move to the whole-gland treatment. Of course, many randomized controlled trials it's now being ongoing, so we will have more answers in the future. It's ready for prime time? The answer is yes, but we have, I would say, 3 things pending. We need a dedicated focal treatment follow-up. Secondly, AI, it's going to help us to determine, for example, if I can predict the PSA drop based in some volume calculation to try to tell you the patient, okay, if your treatment goes well, your PSA after HIFO, whatever, will drop to a certain amount, and we need one better energy be able to be applied in more area of the prostate. And of course, there is a lot of work in that area, and this is my final slide. So focal treatment, we have to think in prostate cancer like an evolving, like a continual risk. Focal treatment is a process that starts when you see the patient and you start planning that with the new biopsy, that potentially this patient is going to be a good candidate for focal treatment. When you do the treatment, and also during the follow-up, it's feasible and safe, it has excellent functional outcomes, very good medium-term oncological efficacy. Improvement, sure, absolutely, but we cannot stop treating patients because the lack of randomized controlled trials, because we have very good real data evidence. Thank you.